Good morning. Thank you for joining PHCA for today's webinar, Goodbye Grace Period, What Will Be Expected from Your Facility Assessment in the Coming Year. I'm Wendy Johnson with the Pennsylvania Healthcare Association. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on the PHCA website later today. The webinar has been approved for 1 continuing education credit for PHCA and HCA member nursing home administrators. Certificates will be emailed, and please note that effective April 1st, I'm required to upload the credits to the NAB registry. So hopefully you've all registered for this free service and have provided us with your unique NAB registry number. Following the webinar, I'll be sending a link to a quick survey. Please complete this survey, and if you're participating in a group setting, have each participant also complete the survey. Your feedback is important to us and our speaker. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your question pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. Today's webinar is being presented by Ellen Kuebrich, Chief Strategy Officer with Providigm. With over 500 changes to existing regulations and 19 new requirements to comply with, the final rule hit the long-term care industry hard. CMS heard concerns regarding the scope and timing of the new requirements for Phase 2 and provided a limited time restriction of enforcement remedies like CMPs, payment denial, or termination for Phase 2 requirements, including the facility assessment. Surveyors were instructed to take it easy, doling out tags for Phase 2 requirements and to use those instances as an opportunity for education instead. But what happens when they stop taking it easy on you? Today's webinar will explore how your facility will be affected when this enforcement relief ends, what will be expected in your facility assessment moving forward, how will this affect other areas of regulation, and what can we expect in terms of deficiencies and penalties in 2019, which we know is going to be here before we know it. This interactive webinar will allow attendees to become familiar with what will happen on and after November 28th, 2018 as CMS relief ends, understand the intent and expectation behind the facility assessment, and become aware of repercussions of having an insufficient facility assessment as it pertains to other related F-tags. I'll now turn the webinar over to Ellen.
Thank you so much, Wendy, and thank you everybody for hopping on this webinar. Hopefully today I can give you some insight into what will be expected from your facility assessment, what you can expect in survey so that you all can be amply prepared by the time that this grace period ends. I think that Wendy said it really well when she talked about the final rule. Over 500 changes, 19 brand new requirements, and all of this with no extra money or staffing or help from CMS. It's a lot for the industry to take. You all are pretty familiar with this timeline at this point. The Phase 1 regulations had to have been implemented by November 28th of 2016. We just hit that big Phase 2 deadline back in November. And the next deadline for Phase 3, we actually skip a year. So it's November 28th of 2019. That being said, there is kind of a deadline in between where this enforcement relief will end. Now, let's talk a little bit about Phase 2, because we're going to talk about the facility assessment today, and that's one of the biggest components of Phase 2. But when we look at things like the QAPI plan that you had to do, the facility assessment, all of those had a real impact on your bottom line, whether you all realized it or not. In the final rule, CMS actually went through each section and they estimated how much time they thought it would take a facility to complete and integrate the requirements of that rule into their business. They took a look at who would be implementing those phase 2 changes, and they gave it a real dollar amount. I don't know if all of you realize this, but when we talk about the QAPI plan and developing your QAPI program, CMS estimates that that should take you about 200 hours every year. And they're looking at a pretty high level resource, right? We're looking at our QAPI committee, our DONs, our administrators. So they're estimating a $40 an hour resource at 200 hours a year, which is a cost of $8,000 to you every year. The facility assessment is going to take you about 70 hours every year. Again, it's a $40 an hour resource. This isn't something that we're giving to frontline staff. It's our leadership in the building. 70 hours at $40 an hour is $2,800 every year. And when we look at the rest of the regulation, once we subtract out the cost for QAPI and the facility assessment, all of the other stuff that you have to do, CMS estimates is going to cost you about $44,000 to comply with. This is a lot of money. I mean, we're looking at around $53,000 every year that it's going to take you to stay into compliance with this final rule. And as I mentioned, unfortunately, CMS isn't handing out checks for $53,000 to each of you, which means we have got to be very aware of what is required and make sure that we're as efficient as possible when we're implementing these changes. And here's why it matters. When we talk about getting your facility assessment done, getting your QAPI plan done, the money here, this is your time that is taking your money, and it's a lot. So this is a huge imposition on the long-term care community, and we realize that. PHCA did a lot of advocating. AHCA, Leading Age, advocated to CMS that, listen, this is too much. You're cutting Medicare, where we're dealing with changes in Medicaid. These facilities are running slim on staff, and you're asking them to do so much more with so much less. You've got to give us a break here. And so CMS heard you, or heard PHCA and AHCA, and gave you some temporary relief. Basically what they said is you can still get deficiencies on the phase 2 requirements. However, there will not be any civil money penalties issued. We're also going to freeze 5-star. So if you do have a really rough survey, you shouldn't see a public effect. Now, you notice that I put a question mark after help is on the way, because yes, I think the elimination of CMPs is somewhat helpful, but it's just on the phase 2 requirements, and you can still get those deficiencies. The 5-star freeze was really, it was dual-sided. It may help those of you that have had a tough time with the new survey, but it's really penalized a lot of folks that have previously had a bad survey, have really improved, and are looking to get that new star rating to bump up their overall 5-star. The only 5-star rating that froze was your survey 5-star. So yes, CMS, I think, tried to do the right thing in terms of giving you a little bit of a break. I don't know how much of a break this is, but here is what you're getting relief on. You are not getting CMPs on the following phase 2 tags. It's not everything, but it's substantial. So baseline care plan, you should not be getting CMPs for. Behavioral health, sufficient staff, which this one hits a lot of people, so to not get CMPs there is a big break. Psychotropic meds related to PRN limitations, your facility assessment, antibiotic stewardship, your QAPI program and plan, and your smoking policies, because there's been some changes in the smoking regulation. Now, that being said, they're not supposed to give you CMPs, and actually, unofficially, surveyors were instructed, even though it's not published anywhere, to avoid even giving you tags unless you just straight up didn't do them. If you did not do a facility assessment at all, you should get a facility assessment tag. But if your facility assessment is maybe not what it's supposed to be, but at least you gave it a good effort, they shouldn't give you a tag, theoretically. They should just educate you. That being said, it's different from state to state. The surveyors are within their rights to do it. It was kind of an unofficial instruction, so you may see that you're getting those tags. But next year, that cushion that CMS is giving you is gone. Okay, so the relief is coming to an end, which means that right now, your work should just be beginning. I'm going to tell you this. You should have something at this point. When it comes to your QAPI plan, when it comes to your facility assessment, you should have something, because you have got to give those to the surveyors in the first 4 hours of them coming into your building with this new survey process. My guess is that all of you do have something at this point. My guess is also that none of you feel really super solid about your facility assessment. And it's not surprising because CMS didn't give a ton of guidance as to what was expected. They released kind of a template document late last year, but it wasn't really specific. And even in the document, they said this is just a suggestion of how you may go about it. You can go about it any other way. And so most people that I talk to say, I think we did it, but I'm not totally sure. And so that's what we're going to talk about today. What should your facility assessment be and what should it do? And I'm going to tell you this, it's more than just a homework assignment if you do it right. It should really help your business if you do it right. I know that everybody feels like it's kind of just one more piece of paperwork that we had to get done in a homework assignment before they come in for survey. But I think that it could be a really meaningful document. And it's interesting, one of the directors of nursing out of Vernon Manor, Christy Doherty, said, when I learned about the facility assessment, I can honestly say I was horrified. I didn't know how to make that a meaningful document that we could build on. And that's what we're going to talk about today. How do we make this something that's not just a task that we have to do, but something that improves the care of our residents and improves the bottom line of our business? Okay, so the intent of the facility assessment, the reason that CMS is asking for you to do this is to evaluate the resident population in your building, who is it that you're taking care of, and identify what it is that you need to take care of them. That's all it is. That's what they want you to do, is proactively take a look at who you're taking care of and make sure that you're able to take care of them. Why is this important to CMS? It's because we consistently see in survey that you are getting tags because you are not adequately prepared to provide the services that you say that you can provide. So let's take a step back. Let's look at what we're saying we provide. Let's look at who we're admitting and make sure that we can actually provide that care prior to there being some type of a care issue. Now, how do you even get started on this? I would say let's start with having a conversation about who should have input into your facility assessment. I see a lot of facilities that will just toss this job on the DON, and while he or she should absolutely be involved, they are a critical piece of the team that should be involved in facility assessment. You are missing the boat if you don't involve more people. Okay, so when you take a look at your facility assessment, and what I would say is, you've got to review this every year anyway. Let this year be the year that you take what you think was okay and try to make it really meaningful. Okay, so let's get our facility assessment team together. At a minimum, it should include the administrator, a representative of your governing body. CMS in the guidance to surveyors defines the governing body as owners, operators, management companies, CEOs, the administrator, the DON, those would all be appropriate to be on the governing body. The medical director at your facility, your DON, right? And these are kind of the no-brainers, but all four of these folks should be involved. I also would tell you to consider getting some other input, department heads, but also frontline staff and residents and families. Who better knows what you need to actually take care of a resident and their conditions than your frontline staff? Do some interviews with CNAs about certain residents and say, okay, walk me through what exactly you would need to be able to take care of this person every day, day in and day out, based on all the conditions that they have. Okay, this is the team that should be made up of the facility assessment. That being said, while somebody from the governing body should be involved, and again, that's owners, operators, management, the facility assessment is not a cookie cutter template that your management company should be giving to all of the facilities that it manages. If you're part of a larger group, it would not be appropriate for your management company to say, hey, here, we did your facility assessment for you, here it is. Because while you might want to include input from your corporate organization, the facility assessment is a facility level document. Now, this is in contrast to something like the QAPI plan, which it may be appropriate for the corporate to give kind of a more of a template of this is how we do QAPI at this organization. And it may be the same process for how you do QAPI in your building versus your sister building. Your facility assessment is not the same in your building versus your sister building because it's all based on who it is that you take care of. Okay, we're going to walk through this, but really what you should know here is this is where you have to start over here. It's your resident population. I want you to take a good look at who it is that you're taking care of. What conditions do they have that we need to consider? because then we're going to walk through this exercise and you'll see that they all will map back to here. What services would you need to provide to take care of these residents? What staffing? That means how much, how often, what level of staff would you need to provide these services to take care of these residents? What competencies would that staff need? What do they need to know to provide these services to take care of these residents? What equipment? This is physical space, medical supplies, medical equipment, health IT. What do they need to do their jobs to provide these services to take care of these residents? And then not only do we need to know how do we take care of these folks day to day, what do we need to do that? You also need to think about what do we do in the case of an emergency? And unfortunately, last year was a very clear indication that we are underprepared in terms of our all hazards approach to emergency preparedness. We had an active shooting in a home out in Northern California. We had several hurricanes. We had mudslides. We had wildfires. How are you going to be able to get the things that you need, the staff that you need to provide these services to take care of these residents, not only day to day, but in an emergency? So that's what we're going to spend the next probably 10 minutes or so walking through, is each one of these little bubbles to make sure that you know what needs to be in your facility assessment here. Let's start with some data sources that you might want to have access to. So that group that we mentioned before, here are some data sources that you might want to consider when you start looking at your facility's capabilities. You know, MDS is a big one, right? It's got all of your residents in there. It's got all of the conditions that they had. Your QMs, how do you perform in terms of delivering this care? If we're underperforming, do we need to look at our resources? Your 802 and 672, and those have really gone away with the new survey. They're now replaced by the facility matrix. The facility matrix of the new survey is available on the CMS website. It is, again, required to be given to your surveyors in the first 4 hours of survey, and it's a lot. I would recommend that all of you go download that document and start working on it now. If you're in your survey window, you know, just get an idea of who's in your building and what conditions they have. But it really used to be the 802, 672. Now it's the facility matrix. Those would be good resources. In-house reporting, anything that you're doing in-house for your QAPI would be good to look at. And your PBJ, right? Staffing is a big part of this. So make sure that you're taking a look at your staffing levels, your payroll-based journaling, get all of this data collected before we meet as a group. And then we're going to walk through each one of these bubbles here. Okay, so the facility assessment, the resident population, and the facilities, or I'm sorry, the services that are required. Your resident population, what are they looking for here? You need to address or include in the facility assessment, first and foremost, how many residents do you have in your average daily census, and what's your capacity? So how many can you take? How many do you usually have? I want you to take a look back the last 6 months to a year and really document. If you want to do this the right way, I would document every single resident's day. And for some of you, that's excessive amounts of people, but you need to do it because otherwise you don't know who you're taking care of. So take a look at every single stay that you had in the last 6 months to a year and start thinking about what diseases each one of those people had, what conditions, what disabilities, what was their acuity level, any other pertinent facts that you need to know about that resident. Things that I think a lot of people forget in their facility assessment that are important are kind of the softer parts. So any ethnic considerations or cultural, religious factors, dietary considerations, food preferences, any other aspect of care that you identified that you needed to know to take care of that person. Once we have all of those stays documented, take a look across all of your stays and start tallying up how often, the frequency that you're seeing each type of resident. Okay, so how often are we treating people with CHF? A lot? A little? Both are important, and I'm going to tell you why. You might think, okay, well, we only really need to consider who we see a lot. You know, if we take a high population of folks with CHF, you know, we for sure need to address that in the facility assessment and make sure that we can take care of folks with CHF. I would caution you that on the flip side, if you don't take very many people with CHF, but you take some, a lot of times you are less well prepared than for those that you treat all the time, right? So if you're treating people with CHF all the time, you know exactly what you need. if we get a random CHF person in that we typically don't treat, that's where we lots of times will see mistakes in competencies and staffing levels. So whether they're high or low frequency, still consider that as part of your resident population, but have a good idea. And if you are not prepared to take care of a resident profile that you're admitting, maybe we need to consider not admitting folks with CHF in that case. Okay. Let's take a look at a sample resident population really quickly. And again, CMS has not given any hard and fast rules over what you need to do, but I just want to give you an idea of what I'm talking about in terms of frequency. So you can see that in my little fake organization here, I have 179 people that have been here in the last year. I'm a pretty small facility. That's 100% of my stays. And frequency, high or low, right? So I'm going to go through each one of these sections really quick, and I'm going to tell you how many of those stays had a certain condition and what that percentage of my stays was. Okay, so you can see that I've got a really high percentage of folks that have high ADL function. This is a good one to look at. Your ADLs, how many people need a one-person assist with any of these items? You know, I've got a high number of folks that need a one-person assist. Two-person assist. Now, this is also a good opportunity as you go through this to look for mistakes in your coding. I mean, how many people really need a two-person assist to walk in their room? The fact that we have 7 coded that way makes me think that maybe there's a mistake. But take a look at it, right? So you need to know these are the people that need a two-person assist with each one of these things. Mobility, how many people are independently ambulatory? How many people have contractures? Therapy, what was the average number of days? How many people were getting that and what percentage of that was? Okay, and then give yourself an idea of what that frequency was. That would be kind of considered under function in ADL. Acuity level, diseases, conditions, and treatments. You know, how many of your folks had genitourinary issues? You know, I have a very high population of folks that have genitourinary issues. Infections, on down. Behavior, cognitive. Go through all of these types of things. So as we kind of go through this, this is the detail that CMS wants. This is why they're saying it's going to take a long time to do, because this is really in depth and you need to do this at least once a year. And we'll talk a little bit more about how often you should really do this in a moment. And then again, cultural factors. So their race and ethnicity. Were there any dietary issues, religious issues that, you know, are there people that want to go to a mass on Sunday? Do we need to provide transportation to get to that mass? That type of thing. Okay, so we'll go back into our presentation here, but that's just an idea of the detail that you all should consider when you're looking at your resident population. So then for each of those categories, I would go by general categories. Add your specifics as needed, but it's not like you need to list out every single disease known to man and say, you know, this is the services that we need to provide, although you would be well within your rights to do so, and it would probably be a more comprehensive facility assessment. You don't need to quantify each care or practice in terms of the number of residents that need that care, and I do not want you putting resident care plans in your facility assessment. I get a lot of folks that say, well, do I need to have everything then for their care plan and just attach all of those and give those to the surveyors? Absolutely not. That is not the intent of the document, and you are going to get yourself in hot water and survey if you just start giving care plans out willy-nilly. Same thing with your QAPI plan. Your QAPI plan is a description of how you are doing QAPI, how you're meeting those 5 elements of QAPI. I don't want you to put QAPI findings in your QAPI plan. Okay, the intent here is to identify and reflect on the resources that you need to provide the type of care necessary for those residents. So I'm going to give you an example. You notice that in that resident assessment, we had a high number of people that had genitourinary issues. Okay, so in the past year, our analysis indicated that we had 14% that you needed a urinary toileting program, 14.5 needed a bowel toileting program. We had some indwelling catheters, external catheters, intermittent catheterization that we had to deal with. So here would be an idea of, this is my resident analysis. Here would be the services that I might need to provide. Bowel and bladder toileting programs, incontinence prevention and care, intermittent or indwelling or other urinary catheter, ostomy, responding to requests for assistance to the bathroom promptly in order to maintain continence and promote resident dignity. Does that make sense? Again, Wendy mentioned, if you all have questions, please type them into that questions pane, and at the end of the presentation, I'll stay on and make sure that I get those answers for you. But this would be what your resident population analysis says. this would be the services that we might need to provide. Okay, next step. What do we need in terms of staffing and what the staff knows in order to provide the services to take care of those residents? Now, the guidance to surveyors outlines that the individualized approach of the facility assessment is the foundation to determine staffing levels and competencies. What you need is clearly based on who you serve. There is such a huge regulatory focus on person-centered care planning. It would make sense for you to think that your surveyors will be taking the same approach when it comes to the facility assessment next year. So look at your overall staff and the number of qualified staff. If we had 10 patients with wounds, I might think that I need a WOCN. What about weekends, vacations, nights? How often are they going to need that service? Where are they assigned? If I have them all on the long-term care unit, that wouldn't necessarily meet the needs of the residents, okay? So the facility assessment needs to include an evaluation of the overall number of the facility staff needed to ensure a sufficient number of staff are available to meet each resident's needs. Okay, so that means who. So who on your staff is going to be able to provide the support and care? Here, you might want to look at staffing records, your org chart, PBJ. Don't forget about support staff, religious services, and volunteers. Those count. So make sure that you have them in there and make sure that you are counting them towards that. Staff scheduling and frequency. How do you ensure that you have enough staff to provide these services? Describe your general staffing plan to ensure that you have enough staff to meet the needs of the residents at any given time. Consider the fluctuation in your census. If you don't have a pretty steady average daily census, make sure that you're adjusting staffing then. We shouldn't have the same staff when we're really full, and if we're 100% full versus 80% full, we should see some differences in staffing. Take a look at the frequency that you're servicing each population profile. And remember, this is not what you have that should go in here, but what you really think you need to adequately provide this service. The regulation provides minimum staffing requirements. When we talk about those staffing ratios that are in the regulation, yes, I want you to absolutely meet those. That's the minimum expectation. And I get that we are on very, very tight budgets and it's really hard to find good people. So make sure you've got the minimum. But again, your facility assessment should take a good hard look at what you think that you really need to provide the services to take care of those residents. Okay, so we're going to do our same example in bowel and bladder. By staff type, we probably need licensed nurses. We need a full-time DON. We need 1 RN or LPN per shift. You've got your ratio of licensed nurses per shift. Your direct care staff, again, you want to have your ratios listed out there. Or you might want to do it by hours per resident day. So how many licensed nurse staff hours per resident per day, RN hours per resident per day, LPN, CNA, and on down. And then look at the staff assignments. So make sure that when you review those individual staff assignments, that they are able to take care of the residents across those staff assignments. If we've got a lot of people that need a one-person assist with a lot of these ADL things, we need to make sure that we've got enough people that can simultaneously service multiple residents so that it's not going one at a time and people are waiting and left behind. Next, what competencies do the staff need to be able to do their job? Competency is a measurable pattern of knowledge, skills, abilities, behaviors, other characteristics in performing that an individual needs to perform work roles or occupational functions successfully. All right, now they have changed what they consider competent, and we'll talk about that in a moment. But in the guidance, it specifically states that you should have these areas delineated as competencies. So I'll let you look at this list, but when we take a look at staff competency, which you should be reviewing every year, make sure that you have these 10 in there. Now, it's not limited to these 10, but if the guidance is specifically mentioning these 10, I would make sure that you have these listed out in your facility assessment and that you have a way to make sure that every year people are competent in these areas. If there's an outbreak of MRSA all in one hall, there's a clear breakdown in infection control. Who is it that can teach the infection control competency? What is it that you require for a staff member to become competent? Who knows about glove use? Those are all things that you should be thinking of in terms of your staff competencies. Here are some competencies that would probably be a good idea in our example of bowel and bladder care. Licensure, basic nursing skills, the ability to identify different types of incontinence, communication, infection control, dignity, use of incontinent products and monitoring devices, and on down, person-centered care, perineal care, urinary output measurement. These would all be things that I would want my staff to be competent in order to provide this service. Now, when we talk about how do we make sure they're competent, you can no longer say, okay, they attended an in-service, we had a lunch and learn, they're competent in infection control. That's a big no. That is not competent anymore. By the end of this presentation, I would not say that you would be competent in what's required in the facility assessment, because it's just a presentation. In order for you to be competent, you've got to be able to use and integrate knowledge, and you have to document that you've assessed and evaluated staff in these areas. So we should have somewhere in our facility where we are dating and documenting how and when staff demonstrated competency in each of the things that we're saying that they should be competent in. So here are things that are okay to say, okay, we did this and now they're competent. If I gave you a lecture and then I turned around, so if I gave you this presentation and then I called you afterwards and you gave me a summary of this presentation, or you gave this presentation back to me, that would be appropriate. That would be a lecture with a return demonstration. Okay, I tell you how we do glove use, and then you show me how you are supposed to change gloves. That would be a demonstration. A pre and post test for documentation issues. So I'd give you a test before we had this, I'd give you a test after, I'd keep both of those tests, and hopefully you would have at least an 80% pass rate, and that we determined that makes you competent. A demonstrated ability to use tools. I place a catheter, and then I watch you place a catheter. Here's who needs to deal with this: nurse leadership, okay? Medical director should have input. You guys should talk about what the competencies are for each role based on who you serve, and then you should be annually monitoring this. And I would suggest that you do it more than annually. You have a lot of turnover, you have people that will learn things and then forget. You need to constantly make sure that your staff is competent. Facility resources, okay? Moving on to the next section. What physical resources would you need to provide care for that resident population? So this is talking about physical space. Do you have a physical space to do physical therapy? That would be part of your facility assessment. That's a resource. Equipment, medical and non-medical, medical supplies, services that you provide. Those are resources. All of your personnel actually count as a resource. Any third-party contracts, volunteers, they should be here. You should list their competencies. Health IT, this includes your EMR, your MDS system, any other point of care systems that you're using. What would you need to be able to take care of these people? And for any of my administrators on the phone, I want you to be well aware that your operating budget is a facility resource. That is why I absolutely need you in the group that is doing the facility assessment, because if it comes back that we didn't have enough staff and they say, oh, well, we didn't have enough money in our budget, well, you should have determined that in your facility assessment. And you should have taken a look at who you're admitting. If you didn't have the staff to take care of them, you should have admitted them. Okay. Remember emergencies here too. So we're going to think about that in a little bit. But for our example, for bowel and bladder, physical space, these are things that you might think of. Do we need privacy curtains? Any transportation? I don't know that we would need any for bowel and bladder, but maybe you do for some reason. Medical equipment and supplies, liners, pads, guards, briefs, pull-ups, catheters, bladder scanners maybe, wipes, peri-wash, gloves for sure, barrier ointments. Those would be resources that you need to provide this care. Health IT, your EMR, your MDS system, maybe your QAPI system if you have an electronic version of a QAPI system. Data analytics and MDS optimization. Your call light system would be one that's important for bowel and bladder. If that's not functioning, and that's why we're not getting to people, that's an issue, okay? All right, the final step is, again, how are we going to take care of these folks during an emergency? Not just during the day-to-day. Like I said earlier, you have got to create a risk assessment that uses an all hazards approach, including missing residents. But this is going to seem almost like Chicken Little with the sky is falling when you do this. I want you to think of every possible weird thing that could happen. Especially in your area. But you'll notice here, biological events, natural events. What if there's a SARS outbreak again, something like that because of mosquitoes, or a West Nile outbreak? How would we deal with that? Radiological events, natural events, chemical events, explosions, trauma events. I mentioned an active shooter. Natural events, snowstorms. I mean, especially up in the Northeast. Last year we saw really extensive blizzarding. In California, we saw the wildfires break out. In Florida and Texas, we had those massive hurricanes that literally closed roads. And what you need to think about is, okay, if the roads are closed, if my facility is filling up with water, what is it that I need to do? What's my plan to make sure that these residents are taken care of? Okay. Now, one of the things they mention in the guidance is what they call an HVA. It's a hazard vulnerability assessment. And it's a really good way to get started on this, because I can't even tell. If you ask me to create an emergency preparedness plan for our office, there's no way I would think of every possible situation. It's because some of them are just so unlikely that I might slip my mind, but I need to think about them. This is a really good way to get you started. And there are a lot of existing documents out here that you can just use. You don't need to start from scratch here. Kaiser, if you Google Kaiser Hazard Vulnerability Assessment Tool, this will come up. You can use this. It will kind of walk you through all of these things. So you can see active shooter, acts of intent, bomb threat, a building move, chemical exposure. If you're by a train track and a train car tips over and there's chemical exposure, what happens? Civil unrest, telephones fail, our generator goes out, dam failure, drought, earthquake, epidemic. So it walks you through kind of all the situations. And then you just go through, how likely is it that this is going to occur? What alerts do I have in place? What activations? What's the human impact, the property impact, the business impact? And then, for any of your ones where you think it's a high probability or moderate probability, I would probably try to put a plan in place to make sure that I can still care for my residents. Okay, so yeah, if you go to Kaiser, it's kaiserpermanente.com, kp.com, I think you can get this. The California Healthcare Association, which is CAHF, also has a really good one that is free and available if you search for that tool. So use your resources. Don't feel like you need to start from scratch. There's a lot of people that have done a lot of work on this already. Just take advantage of that. Okay, ongoing review. When we talk about how often you need to review things, the requirement is that you review it at least annually. What the regulation says is that you must review and update this assessment annually, or whenever there is or the facility plans for any change that would require a modification to any part of this assessment. So what does that mean? They give you a good example. Like if you all of a sudden decided that you were going to start admitting bariatric patients and you hadn't before, then yeah, you should look at your facility assessment and see what resources you would need to add to take care of this new population. Okay, so it's not the intent that you're updated for every new person. If you admit one bariatric person, you probably don't need to update your entire facility assessment based on that one person. But it's significant changes when you begin admitting residents that require substantially different care. If you build a vent unit, review your facility assessment. That being said, I can tell you when I would review it again, and it's right before your survey window opens. Because if you take a look at your resident population, let's say that I did this in January and my survey window opens in November. And in those 10, 11 months, I had some population kind of start coming in, trickling in one or two at a time that, maybe I didn't notice because it wasn't like a huge change, like a vent unit, or I was going to start accepting bariatric folks. I mean, if it was just a one or two, but it was maybe one or two every other month, now I've got some sort of a population that has this condition that I need to review. And a surveyor, when they look at it, doesn't know, okay, well, they did it in January and maybe these people just came in. I'd probably take a look at it. Make sure that your resident population analysis still seems appropriate, that there's no surprises in there, and that if there are, that you run through that exercise with them. Okay, so I would tell you, if you want to be safe, do it annually. I would also take a look at it before your survey window opens up. And then obviously if there's any substantial change. Okay, so we talked about kind of what should be in it. Let's talk about what you should do with this. Again, my goal for you here is that this isn't just a ton of work. It's that this is a usable document that helps you to manage and run your facilities better. So the goal of this is to help you to make decisions about needed resources, including direct care staff needs, their capabilities, and how they're able to provide services to the residents in the facility. So as we review our facility assessment, and I would say, you know, all of us, like I said, you should have something at this point. You should have done a, you know, quote unquote facility assessment. And maybe you're not feeling sure after listening to this presentation that it's where you want it to be. That's okay, right? We've got this grace period. I want you to take a look at it though, and review it at some point, and I want you to start to use it. So when we look at our resident population, does your resident population analysis reflect the types of people that you admit? Has it changed? Are there new segments that weren't there before? One exercise that I always find really helpful to do with folks is pulling up their website. What does your website say about who you admit? Do you feel like you can take adequate care of the people that your website says that you can admit? If not, you know, we might need to fix our website. We might need to make sure that we've got the ability to care for those people if we don't want to fix our website, okay? Has our population changed? Do we have a good handle on who it is that we're taking care of? Your staffing types and levels. Based on the staffing that you said was necessary to care for your resident population. Remember, in your staffing section, I don't want you to put what you have. I want you to take a really honest look at this and say, what do we really think we need in order to take care of these people the right way? So based on that, do you need to make any changes in your staffing or your scheduling? I'll say it again. Resident and CNA input is really valuable here. Go talk to your residents about the staffing levels. I know that every resident will say there's not enough staff. I don't get the help that I need in a timely fashion, and to them that's 30 seconds. But go talk to them, because if they're saying it to you, guess who else they're going to say that to? Your surveyors. And we don't want the first time that we're dealing with this to be when a surveyor brings it to us. Talk to the CNAs. Are they feeling like they're able to get through their work in the day in a timely fashion, or are they feeling really stressed like they can't manage it? How well is the current staffing working? Keep in mind, yes, you have to meet those minimum standards. But if you think you need more than that, then let's take a look. Again, that operating budget is one of our resources. And if we need to rearrange some things, if we need to take a look at who we're admitting, if we need to consider admitting less people so that we have the right staff, let's think about that. Look at your QMs. How do you compare to the rest of the state? Look at your staffing levels on nursing home compare. How do you compare to the rest of the state? If we're way low, if we're a 1-star in staffing, I would want to know what's going on. I'm sure that you all do know what's going on. Maybe it's that you can't find good people to hire. Maybe it's that we just are really strapped thin with our budget, but you need to know that, and you need to consider it in your facility assessment. If you are strapped so thin in your budget that you cannot get the staff that you need to provide good care, then you need to admit fewer people, because your job is to take good care of these residents, right? Your competencies. Don't forget behavioral health, because while this is not being, you're not getting fines for this. Theoretically, they shouldn't really be citing you as much for this right now. I think next year it's going to hit hard. So don't forget behavioral health as a competency. Look at infection control. It's pervasive. If I see infection control as a surveyor, it is very rare that it's not a systemic issue. And it's not just in nursing. You know, I might see a CNA, you know, we call it the magic glove effect, right? They've got gloves on, they think they can touch everything, or they're putting gloves on top of each other and just taking off a pair of gloves. It's not a good practice. It's not rare for me to go walk into the kitchen and see that there's infection control issues there too. So it's a pervasive issue. That's why there's this requirement to get an infection prevention control officer on staff. And that requirement's in 2019, but again, start looking at it now. CNA training. There are competencies described in the guidance that CNAs are required to have. So make sure that you have those in there. Take a look at people's job descriptions. You know, if you're kind of going through it and you go, gosh, you know, I really don't think that they need this competency, but their job description kind of says that they might, then maybe we need to take a look at job descriptions and titles. Are these competencies reviewed annually in our review process? So the last thing that I want to do is see there's an issue in infection control, and then a surveyor goes back and looks at competencies, and the last time that you checked that competency was in 2016. So make sure that you're reviewing them at least annually. Are there any more opportunities to closely collaborate with medical professionals to enhance care? Do we need to get our medical director more involved? Do we need to get our physicians more involved? And this might bring that to light, and that's okay. You want to use this. This should be a meaningful document to change the way you're giving care in your facility. Physical resources. Do you have the space to provide the care that you're advertising? Do we have the right equipment and supplies? Have we educated ourselves on innovations in these areas? You should lean on your vendors here. You know, Medline sponsored this webinar. it would be a good idea to just ask your reps once in a while. If you have a DME rep, if you've got a medical supply rep, like, these are great resources. Say, hey, is there anything newer or better that could help us to be more efficient? Just educate yourself. You can always say no, but lean on your vendors. See what they have going, because maybe it will help you to provide care more efficiently, which could be what we need to free up more staff, right? Have we talked with our medical suppliers about what will happen in an emergency? If those roads are closed, how are you going to get your supplies? If those roads are closed, how is the medical director or a doctor going to be able to get to the facility? Again, lean on them. Ask them what their plan is. They should have emergency preparedness plans to help you out. Are there IT solutions that you need to more adequately assess and care for the population that you serve? Again, it's never a bad idea to take a look at what's out there in the market. There's a lot of really neat systems that can help you to do your job better and more efficiently. Again, CMS is asking you to do so much more with so much less. At some point, you're going to need to create efficiencies that weren't there before. And software systems are a good way to do that. So take a look when you go to trade shows, when you go to the PHCA annual event, if you go to the ACA annual event, take a look at the vendors that are there, see if there's anything that can help you out. And then if there are any areas where you don't think we've got the right services or the right staff or the right competencies or the right physical resources, this is where you should start utilizing QAPI. It's a whole different phase 2 requirement, but it is going to come into play here. If you make a change, measure its success. If you change the way that you're measuring or doing competencies, if you add more staff, try to find a way that you can measure if it's successful. And probably a good measure would be, talk to those same residents. Do they still feel like there's not enough staff? Things like that. That's a measure, but make sure that it's consistent over time. And then are any adjustments needed in your budget? And this is where that administrator comes in. And I know that this is scary because this is a big undertaking, and it is different than a homework assignment that you're going to present to a surveyor, because when you do this right, what this really should be is like a gap assessment. This should show you where you have some holes in what you're doing. If you take a look at what you said you needed to actually do your job and you don't have it, I know that that's a scary feeling. But what I want you to do is create an action plan and document it. Again, this could mean looking who we admit, it could mean adjusting resources. But if you have an action plan in place, if you've identified a gap prior to a surveyor coming in, you have a way better chance of not getting cited there. And frankly, when you have the capabilities to take care of your residents, when you have the right services and the right capabilities, you're going to see better outcomes. You're going to see happier residents. You're going to see happier staff. Frankly, I would tell you, you probably will see a boost in your census. But this is why you're looking at this now instead of when the grace period ends. I know that you guys have kind of a free pass this year, and you might have something that's your facility assessment that's done, but this is not the time to be like, okay, well, we're okay for a year. Because when you're not okay anymore, when they are going to be more harsh, I don't want you to get caught unaware. Look at this now. Find out where you've got those deficiencies, those gaps in performance now, and fix them. All right, I want to spend the last few minutes here just talking about what will happen in survey, and then we can open it up to questions. But what will happen in survey? Perception versus reality. I hear a lot of people saying, well, I just have to have a facility assessment, right? And yes, this year you have to have something that says facility assessment on it that takes at least a little bit of a venture down that road that we just went down. That does not mean that you will not get the facility assessment tag. And it's only going to exacerbate next year. So yes, this year, have something to show a surveyor, but just be aware that you can potentially get tagged for facility assessment another way. Because when we look at the surveyor guidance, the facility assessment is mentioned as a related F tag that a surveyor can tag in all of these areas. Abuse, comprehensive care plan, accidents, dietary, sufficient staffing, comprehensive assessment, food and nutrition, menus and nutritional adequacy. All of these mention the fact that infection control down there. If you see this, I want you to look at the facility assessment. That's what the surveyor's instructions are. So I'm going to give you an example of how this can spin out of control. Let's say that during the resident and family interviews that the surveyors do in this new survey, there are 3 to 4 people who have had incontinence episodes. And when we talked to them, they said, well, I didn't get the help that I needed. Let me show you how this can mushroom out of control. Now we're looking at 725 for sufficient staff. Okay. The guidance under there is going to say, hey, was this an issue in the facility assessment? Do they not have sufficient staff to provide the care that they need? That facility assessment, which we'll talk about in a minute, is actually listed under the administration and governing body. So we could be looking at an administration tag. Obviously, if we're having incontinence episodes, we might be looking at incontinence tags. During that, they're going to ask the residents how it made them feel when they had the episode. Did you feel bad, embarrassed? Probably, right? Now we're looking at a dignity tag. So be aware that this is a big deal. The facility assessment is a bridge to tons of tags for one issue. And I want you all to be aware of that. When we look at the surveyor procedures, this is what it says in the guidance here. So if a systemic care concern is identified, review the facility assessment. Determine if those concerns were considered as part of the process. Again, if they started accepting bariatric patients and there were concerns about bariatric services, did they update their assessment before accepting residents with those needs? Here are the questions that they're told to ask. This is in their software. Not limited to these, but this is what it says that they should ask. Who was involved in conducting the facility assessment? How did they determine what equipment, supplies, and physical environment would be required? How did they develop their emergency plan? If a deficient practice is systemic and it's observed in another tag, was this related to an incomplete facility assessment? How? So they will be looking at this. And this is going to get a little bit scarier because if we look at who's responsible per the regulation for the facility assessment, it is administration, which means it's the governing body, management companies, owners, operators, CEOs, administrators. It's you. So now we're getting into those administration tags, which we absolutely don't want. It's under the guise of administration. So you'll see that when we take a look, governing body, which is kind of phase 3, when in the QAPI program. So when we actually have to execute our QAPI program, you'll see that we have the governing body that's a required part. They are over administration. Administration's over the facility assessment. The facility assessment involves the QAPI plan and the QAPI program, because this is how you should be identifying if things are wrong, if they're not working, so that you can address them in your facility assessment, which means that a single failure on the floor here, or a systemic failure on the floor, I can say, can easily be mapped back up to the governing body. Okay, and in the guidance, like I said, owners, CEOs, management, operations. Okay. They are supposed to cite this tag if the actions, inactions, or decisions in administering the facility contributed to the deficient practice. Okay, so when we have that negative survey outcome, you know, if we said it, you know, we had those incontinence episodes because we didn't have enough staff, they're going to say, well, why didn't you catch that in the facility assessment? Why did your QAPI not catch that these people were having these incontinence episodes and not getting the care that they needed? That's the job of administration. That's the job of the governing body, which is why if you put this all on the DON, you're putting yourself at risk. Be involved in this for sure. So what now? Yikes, right? That's a lot. I know it's a lot in an hour. Get started. You've got this breathing room. Okay, this is why you are listening to this webinar, I hope, is that you're not going to just sit on your laurels and wait until it actually counts, right? So don't treat this as a homework assignment that you have to do. This is a really good opportunity for you to streamline your business and improve care. Get the right people involved. Be critical. Okay, this is, again, yes, you're going to show something to the surveyors, but if there's really an issue, I want you to find it. I don't want them to find it. So glossing over it and putting on your rose-colored glasses, burying your head in the sand, whatever you want to call it, and pretending that you have the resources that you need if you don't, is only going to hurt you. So try to find out and then be honest about changes that you may need to happen for you to improve. So Wendy, I'll probably open it up to you. I wanted to leave a few minutes for questions if we have any of those. Again, if you have those, type them into the questions pane on the control panel and I can answer them for you.
Thank you, Ellen. That was great information today. We had a lot of people on the call today, and there are questions coming in. Ellen, I'm not sure if you can see them. I did turn them over to you, so I'm not sure.
Wendy. Wendy, did we have any questions?
Yes, we do have questions. Can you hear me, Ellen? Ellen, can you hear me?
Okay, we may have lost Wendy, but I will tell you what, I will get a copy of all of the questions that everybody has asked, and I'll make sure that I can answer them individually for you. Oh, our audio connection was Wendy, did I?
Ellen, can you hear
Yep.
me now?
Oh, I can. I'm sorry. Now I can hear you.
That's okay. I'm not sure what's happening. Thanks. Great webinar today. And there are questions coming in. I did turn those over to you. I'm not sure if you can see them now or not. If not, I can go ahead and read them. In your
I
questions.
can't. If you wouldn't mind picking a few to read.
Nope, that's okay. I'll read them off for you. We'll take a couple minutes on questions. The first one is, do you have to show the competencies of contract rehab therapy
staff?
I
don't know that I can, Wendy. It's showing me a questions pane, but it's not opening.
Okay, that's fine. That's fine. I can read them.
Okay, so do you have to show the competencies of contract rehab therapy staff? The answer there is yes. So any contract staff that you have do need to be assessed in terms of their competencies. You need to have them documented, and you need to make sure that they're competent, because if you're relying on them to provide services for you that you're advertising, then you need to be the ones responsible for assessing their competency. Now, you can outsource that in the same way to the contracting company. If they are documenting competencies, that you can have that documentation. To be extra careful though on things that could affect you, like infection control, that kind of thing, wiping down equipment, that might be something that you want to assess. Okay.
I'm going to read the questions that are not specific. If they're sort of general questions, I'll go ahead and give those. Otherwise, Ellen will answer those offline if they're more specific to your own facility. So the next question that I have is it necessary to do an actual inventory of DME, supplies, and equipment?
So that's a great question. The short answer is yes. I don't know how you would be able to assess whether you have the right equipment and enough equipment unless you're doing an inventory. Now, do you need to include that inventory in your facility assessment? No, but it should be part of the process. What you need to include in your facility assessment is kind of an answer, yes or no. Do you have the correct DME equipment and supplies to provide the services to take care of those residents? I don't think you need to include the inventory in the facility assessment, but you should absolutely do an inventory in your internal process.
Okay, I'm getting a lot of questions around whether the PowerPoint will be made available. Yes, it will be. It is on the right hand of your screen under handouts. You can pull that up, and I believe you can print it from there. Or I will be including a link to the slides in a follow-up email. So either way. It's also going to be available later today on the PHCA website. And yes, the webinar is being recorded and will be made available on the PHCA website later today. Let me throw out one or two more questions here, and then we'll wrap it up. And any other questions, we'll have Ellen answer individually. The next one is, does the infection preventionist have to be on your payroll? Can they be in a consultative role?
So there is not a regulatory requirement that answers this specifically that says, yes, they have to be on your payroll. So in that sense, yes, you could hire some sort of a consultant. That being said, this is a big role that really would need to be present day to day in your facility at some point to be able to ensure that infection control practices are being monitored, that antibiotic stewardship is being conducted, and that there aren't any breaks in infection control practice. Just from a survey perspective, I can tell you that, day one, when surveyors come in, everyone's kind of on their best behavior. Days 2 and 3, everyone kind of settles into their old habits, and those breaks in infection control become much more apparent. I would assume that the same thing would happen with a consultant that shows up once in a while. That one day that the consultant comes in, everybody's on point. But then day to day, they might falter back to some bad habits. So just make sure you're aware of that. I think that it would be appropriate to have somebody in a consultative role. You do need to list them in your QAPI plan under governance and leadership. They should be on your QAPI committee. They're a required role. So they need to be there for those meetings. I would suggest that you have some sort of way to ensure that they are there pretty often. So I think it might be easier to have somebody on your payroll that's maybe doing a dual role. But there's no regulatory language that says they have to be on your payroll.
Okay. We'll take one or two more questions here. How detailed does the facility assessment need to be?
That's a good question. I would say that your resident analysis should be pretty detailed, just for your own benefit. In terms of what you're showing surveyors, I think that you need to remain somewhat general in terms of your analysis of what services you need to provide. Be pretty specific on the staffing levels that you want to have. Don't do anything that can get you into hot water. If you say we need to have X amount of staff and we've assessed it and we have that many staff, and then when the surveyors come in, you don't at all. I mean, now all of a sudden it's pretty evident that that would be a hole. Unfortunately, like I said, CMS hasn't provided a ton of guidance on what's going to be expected. What I think is happening right now is that you all are still in the honeymoon period of this new survey. So some of you may have had the new survey. My guess is it didn't go too badly. There are some states that are really getting hit hard. It's kind of going state by state. But most states, it's not going too badly. Your surveyors, by and large, are still learning this process. They are being forced to use computers, where about half the country was not using computers before. And so I think they're still learning. They're taking it easy on you. They're instructed to take it easy on you. Don't get lulled into a comfort zone. Unfortunately, because of that, we don't know the full expectation of what's required. I think at this point, utilize your surveyors. They're supposed to be educating you here. If you have a chance to kind of talk to them about the facility assessment after the fact and just say, is there anything that you would say that we should have had in there that we didn't, ask for help from them, because they're going to be the ones state by state that determine how specific it needs to be.
Okay, great. One more question here, and then, like I said, any questions that were unanswered, I will send to Ellen, and she will answer them directly.
I'm sorry, Wendy. Okay.
Last question is, can we access the software you showed to do the assessment where you gathered your information?
I'm so sorry, Wendy, but my audio is cutting out again. I can't hear you.
Okay, I think we're going to end the webinar now. Thank you, everyone, for attending today. Just a quick commercial. PHCA is having our annual quality symposium next Tuesday, May 22nd, here in the Harrisburg area. Medline is one of our gracious sponsors. There's still time to register, and if you haven't done so, please check out the PHCA website for more information. Again, I'll be sending a survey. It will be emailed to you as well as a recording of today's presentation, and both the presentation will be made available on the PHCA website at www.phca.org. Please take some time to complete the survey. Thanks to Ellen for the great information today, and everyone have a great remainder to your day. Thank you.